Good morning. In this session, I'll talk about three topics of regional anesthesia that is published in the last 5 years and also might influence our clinical practice. I do not have any conflict of interest. I do get small amount of royalty for my book, Anesthesiology in Training Exam Review, and I also get a funding from our medical school for my research. My first article is about Exparel. This article published in Anesthesiology in 2021. Actually, at the same time, two articles published. One is Hussein 2021 and another is Brian Ilfeld, and at exactly the same time. So for the sake of time, I will just talk about this Hussein article. The Hussein was an anesthesia resident at the time he published this meta-analysis for anesthesiology, which I think is pretty impressive. So we don't see very often that anesthesiology resident will publish an article, meta-analysis especially in anesthesia journal. So anyway, Hussein and colleagues compared effect of liposomal bupivacaine and non-liposomal bupivacaine perineural, applied perineurally for peripheral nerve block analgesia. Their primary outcome is 24 to 72 hour area under the curve pain score, and they included 9 trials as you see here. And when they included 9 trials, they did not find, they found statistically but not clinically significantly lower pain score with liposomal bupivacaine. But when they removed one trial that is industry funded, the difference was not significant statistically or clinically. As you see that no significant difference in individual time points, opioid consumption, time to first analgesic, or patient satisfaction. So now you might ask why they cherry picked the articles, why they removed the industry sponsored article. As you know, the industry sponsorship has a significant bias, and previously it has been shown that our clinical scientists who conduct this trial, analyze the data, they get compensation, honorarium from the companies, which makes significant conflict of interest. And this is no exception in case of liposomal bupivacaine study. 46% of the liposomal bupivacaine was found to be superior to comparative drugs in 46% of the cases in a conflicted trial. That means trial that is pharmacy sponsored trials. But it was found to be superior in only 11% of the non-conflicted trial. And previously, they learned and colleagues found that industry-funded trials likely to favor sponsors product with a relative risk ratio of 1.27. Turner et al. In 2008 also shows that publication rate of industry-sponsored trial is almost 90%, 98% when there is a positive outcome, whereas it is only 37% when there is a negative outcome. And when they publish negative outcome, there is always caveat. They might say that it is maybe underpowered, it may be strong effect of the placebo, or there is some technical error. Only 8% of the time they accurately represent negative outcome. So I am going to skip these 2 slides, and next I will talk about science in the courtroom. And after publication of these 2 articles in anesthesiology and with associated editorial, Pacira Pharmaceuticals, which is the maker of Exparel, they sued American Society of Anesthesiology and asked for retraction of these articles. Few months later, US District Court ruled that drug maker failed to state a claim of trade libel. What is trade libel? Trade libel is the intentional disparagement of the quality of the services or products of the plaintiff's business. And these two studies, lead authors, one of them is Nasir Hussain. I mentioned to you, he was an anesthesia resident at the time. And Brian Ilfeld is well-known clinical researcher in our field. And both people are a very nice person. I don't know why they will do intentional disparagement of the quality of the services by Pacira. Anyway, Pacira appealed that decision in March 2023 and they lost again. Then few months later, ASA, American Society of Anesthesiology, announced the receipt of 2.5 million donation from Pacira to advance education and innovation for our members. Hopefully this will mark a resolution of this conflict. So next we talk about impact of science on stock market. After publication of these two articles, most likely that some hospitals restricted the use of Exparel. And here you see that publication of the article in 2021 February, and after a few months, Pacira filed lawsuit, and here is the district court ruling, and Pacira stocks plunged by 60% from the original value in the next couple of years. And this shows the impact of science on stock market, which we have other example as well. So bottom line, the meta-analysis showed the Exparel did not show clinical superiority over non-liposomal bupivacaine or ropivacaine. And this is unsurprising because when post-market application, FDA advisory board received the post-market new drug application, and they reviewed and they commented that it raised significant concern about lack of active comparator group, lack of safety studies, and lack of evidence for opioid sparing. FDA advisory board voted 6-4 against expansion of the Exparel to other indications. But FDA expanded the Exparel to other indications anyway. So just to note that cost of the Exparel versus non-liposomal bupivacaine is significant. Cost of the Exparel is 266 milligram for 20 ml vial, and which cost $334, whereas cost of non-liposomal bupivacaine equivalent amount cost only $3. The next topic I will talk about peripheral nerve stimulation. Peripheral nerve stimulation has been used for a long time in the chronic pain, but recently there is some interest to use it for acute pain. And a few papers published in the last few years. I will go over one article. And pulse, the reason of the interest in acute pain, partly due to development of the miniature devices, a miniature pulse generator, which can be easily placed with simple tape in the patient's body. It was not like that before. And technically it is very similar to peripheral nerve block. You then needs to be higher gauge needle, 14 gauge needle, and to the needle we pass a very thin electrode and close to the nerve, and the nerve is attached to the pulse generator. And if it's successful, this technology have significant advantage over local anesthesia based technique because you can avoid limitations like motor blockade, like using for a small amount of time, and use of continuous infusion of the local anesthetic. So this is a Dr. Brian Ilfeld study. He published this study in July 2021, and in this study they placed peripheral nerve stimulator to the sciatic nerve for the major foot and ankle surgery, femoral nerve for ACL repair, and brachial plexus for rotator cuff tear. So after the placement of the PNS, they injected local anesthetic and preoperatively, and after the surgery, they randomized the group into two, 1-to-1 randomization. One group got stimulation, another group got sham stimulation. And here you see the data in postoperative day 1 to 7, neuromodulation group, median opioid consumption only 5 milligram, whereas in sham group is 48 milligram. In neuromodulation group, mean daily average use of opioid is 11, whereas 31. And here is the just data extrapolated, and you see that robust effect of neuromodulation, which is marked in the red, and blue is the sham stimulation. So bottom line is PNS is promising, a new technique for postoperative pain management, but more research is still needed. We only all the articles we see published from Brian Ilfeld group. Would like to see that other group also show some similar data. And PNS has, as I mentioned, there is significant advantage over traditional pain management techniques like local anesthesia based techniques. You can avoid motor blockade. PNS does not cause motor blockade or sensory deficit, which you commonly see in local anesthesia based techniques. And no medication bag is necessary, no medication refill is necessary, and it is and it has long-term use. You can keep it up to 60 days, whereas local anesthesia we use usually typically 7 to 10 days. So next topic I will talk about thoracic epidural analgesia failure. I can start with a good story. My anesthesiologist friend unfortunately diagnosed with kidney cancer, and he had open abdominal surgery, nephrectomy. So he had epidural placement, thoracic epidural, and he got very good relief. And in the up to second postoperative day, he was not feeling that he has such a big surgery. So then postoperative day 2, nurse forgot to refill his local anesthetic bag, and he was in excruciating pain. He was crying. He said everything they are giving, and IV medications, high dose IV medicine not working, and he had really tough time in the pain management when epidural was paused. So this is a good story, but epidural frequently fails. So my colleague and myself recently wrote a communication to British Journal of Anesthesia, and we commented on the factors that is responsible for high rate of failure, thoracic epidural failure. One of them is extreme chordal angulation. As you see that these two spinous processes are very close to each other and extremely difficult to pass two needle through this narrow space. And oftentimes you feel resistance, the needle can slip to the paravertebral place. The other problem is fusion of the ligamentum flavum that's very risky. That means you don't feel the ligament and needle go directly hit the cause dural puncture. And you can also have other than extreme, you can also lots of resistance use technique has a low specificity, which we usually rely on blind techniques. So the Kumar and colleagues in 2024 summarized some of the techniques we can utilize to reduce the thoracic epidural failure. One of them is contrast epidurography, which is actually very simple. In the preoperative area, we place epidural as usual, like a blind technique, and after the surgery, when patient transported to the recovery unit, we give a small dose of contrast and look at the X-ray image. And if X-ray epidurography shows this epidural catheter is not in the right place, we redo the procedure. We sometimes needed to do a second or third time. So, but problem with this technique is you must interpret the epidurography image, which as a chronic pain physician do it routinely, and they might help you in interpreting these images. And another thing you can do live fluoroscopy guidance. And I know that some of the institutions already incorporated this in their practice. They have a C-arm in their preoperative area, and they do thoracic epidural under X-ray guidance. Again, it is your chronic pain colleagues can teach you the technique because they do this very routinely. And epidural catheter waveform and electrophysiological stimulation are still in the experimental phase. We need few more years to get more data about efficacy of these techniques to reduce thoracic epidural failure. So in summary, thoracic epidural analgesia is a valuable technique for open abdominal and thoracic surgery, but is associated with significant failure rate. Up to, in our analysis, it shows 20 to 50%. And techniques such as electrophysiological stimulation, waveform monitoring, ultrasound guidance, or X-ray epidurography can significantly enhance success rate. Thank you very much.